Hello everyone, this is Dr. Drmuhdasad and I am doing my fellowship in radiation oncology, and today I will discuss RT indication in carcinoma of breast. Before discussing this, I will briefly discuss what is radiation and how radiation causes cell death, and after that I will discuss RT indication in carcinoma of breast. This lecture is dedicated to Dr. Arif Jamshed. May his soul rest in peace. He was not only a great mentor but was a guiding light to me and many others. Today, his legacy continues to inspire me and many others. So, let's begin with what is radiation. Radiation is energy emitted from an atom or nucleus in form of waves or particles when transmitted through a medium, and that medium can be air, vacuum, human tissue or some other material. And we all know that these media are composed of atoms. So radiation is of two types, ionizing and non-ionizing, but our focus will be ionizing radiations. So what is ionizing radiation? Ionizing radiation is a type of radiation that is powerful enough to eject electrons when it passes through a medium, and this process of ejecting electron is called ionization. And if there is raising of an electron in an atom or a molecule to higher energy level without ejection of electron, that process is called excitation. When a single event of ionization occurs, it releases 33 electron volt of energy, and we all know that for carbon bond to break we need only 4.9 electron volt of energy, and this is approximately 6 times more energy. That is enormous energy, and that is the reason that this ionizing radiation is destructive and is beneficial, and that it will cause the cell death of cancerous cells. So regarding ionizing radiation, these are of two types, electromagnetic radiation and particulate radiation. Particulate radiation, by name it suggests that it will discuss about particles. So this is the energy with mass and sometimes with charge. It transmitted from a material, from a medium. It can be of alpha particles, beta particles, electron, neutrons and protons. While the electromagnetic radiation, in this radiation only energy is in motion, and we have radio waves, microwaves, infrared rays, visible light, ultraviolet rays. So how radiation causes cell death? Before describing this, I will discuss X-rays and gamma rays. They are similar in properties, but their mechanism of production is different. X-rays are produced when fast-moving electrons are made stop by heavy metals like tungsten, while gamma rays are produced by the nuclei of highly unstable atoms when they disintegrate by emitting certain rays to achieve stability. And when they emit rays to achieve stability, only then gamma rays are released, and this process is called radioactivity. How radiation causes cell death? So radiation causes cell death by two mechanisms. There is direct damage as well as indirect damage. And direct damage is done by all charged particles that are directly ionizing, and they have high LET. LET is linear energy transfer. I will discuss this in upcoming lectures. So the other damage is indirect damage, that is done by X-rays photon, and that is due to free radicals. And how that occurs? When X-rays, they ionize water molecules and they generate hydroxyl, and that will lead to free radical mechanism, and that will cause the cell damage. So in summary, ionizing radiation, they will cause direct or indirect damage, and that will cause double strand break in DNA, and that will lead to cell death of a cell. So now we can define what is radiotherapy. Radiotherapy is defined as the treatment of diseases by ionizing radiation. So now to the main topic. What are indications What are indication of RT in breast cancer? So first is adjuvant setting, adjuvant breast radiotherapy. All cases of DCS with complete white local excision will have adjuvant RT, and all cases of invasive breast cancer after BCS they will have adjuvant RT. And we can omit RT in invasive early low risk elderly patient based on PRIME 2 and CAL-BG trial, but they also can have RT benefit. So RT reduces loco-regional recurrence from 30% to 10.5% at 20 years and breast cancer deaths by 54.4% at 20 years. This meta-analysis showed reduction in local recurrence approximately 50% and improves breast cancer mortality. Regarding boost after BCS, it decreases ipsilateral tumor breast tumor recurrences, and these two trials showed this thing. And ASTRO guidelines on boost recommend that a patient who is 50 or less than 50 will have boost after BCS, and those patients who are from 51 to 70 years of age with high grade they will have boost. And a patient with positive margin is like microscopic tumor present in 1 mm of the resection margin, and other high risk features include triple negative breast cancer and HER2 positive disease. Regarding lymph node irradiation, when 4 or more positive nodes are present, lymph nodal irradiation is indicated. When extranodal extension is positive, and if there is inadequate dissection, and when two positive sentinel lymph nodes with no axillary dissection, again lymph node irradiation is done. And regarding internal memory nodes, if they are positive, they are irradiated, and when the tumor is central or medial, again internal memory nodes are included in radiation. So if level 1 axillary lymph nodes are involved, there is more than 5% of risk of subsequent supraclavicular fossa recurrences. But when 4 or more lymph nodes are positive and one is more than 2 cm or level 3 nodes are involved, then there is 15 to 20% of risk of supraclavicular fossa involvement. So RT is indicated, and these two trials they showed 3 to 5% of disease free survival in patients who underwent regional nodal irradiation. So now let's discuss post-mastectomy radiotherapy. So absolute indication includes T3, T4 or stage 3, 4 or more than 4 positive lymph nodes, positive surgical margin. Ink margin is considered as positive surgical margin, and when there is inadequate axillary dissection, like if less than 10 nodes after neoadjuvant chemo, that is inadequate dissection. But if patient underwent upfront MRM, then 6 node, and if they are negative, that is considered as adequate dissection. Regarding relative indication, if 1 to 3 positive lymph nodes, closed surgical margin, multicentric disease, or patient who is young with one or more risk factors like T2, T3 tumor, grade 3, ER negative, LVSI positive, or lobular histology, because these patients have 10 to 20% of risk of local recurrence. So the main point of post-mastectomy RT is that high risk patient, especially those who have node positive disease, they derived overall survival benefit from post-mastectomy RT. This trial, this reported a 9% absolute increase in survival rate at 15 years after post-mastectomy RT in all groups of node positive patients. So these are indication. Regarding post-mastectomy boost, post-mastectomy scar boost is given with or without bolus in patients who are at high risk of recurrences. And this is the summary of my presentation, my lecture, that after BCS, all cases of DCS, ductal carcinoma in situ with wide local excision, and all cases of invasive breast cancer. Regarding boost after BCS, age less than or equal to 50 years, 51 to 70 age with high grade, and when positive margins are there. Regarding regional nodal irradiation, 4 or more than 4 positive nodes, inadequate dissection, more than 2 positive sentinel nodes with no axial dissection, and when extranodal extension is positive. Regarding internal memory node, if they are positive, they are included, and when the tumor is central or medial tumor. Regarding post-mastectomy RT, when the tumor is T3, T4 or stage 3, and if 4 or more than 4 positive nodes are involved, and when positive surgical margin, that is ink margin, and if there was inadequate axillary dissection. Regarding relative indication, 1 to 3 positive lymph nodes, close surgical margins, and multicentric disease, as well as that high risk patient. So thank you, and if you find any errors or mistakes or any updates, please do mention those in comments. Thank you so much.